Welcome to G-Echo. G-Echo is hosted by the Gastro Foundation in association with Project ECHO, the University of New Mexico. And just a reminder that these sessions are held every Wednesday, weekly. Please do feel free to interact, and let's make the session as interactive as possible. And remember, if you have any questions, please post them in the chat and we will try to address them. This week's speaker, I think, doesn't need any introduction. I think we're all familiar with Prof Sandie Thomson. He is probably one of the most experienced, if not the most experienced endoscopist, as well as trainer, not only in South Africa, but throughout Africa. It's an honor to have hosted training sessions with him. And every time we have one of those little sessions, I've had the privilege of having a few with him. I honestly learned something new from him, and it feels like I'm more the trainee than one of the co-trainers with him. So without further ado, let's hand over to Prof Thomson, and I'm sure he has some interesting cases to share with us.
Thanks very much, Vikash. Let me just share my screen and then I can hopefully... Just let me know if that's the right way around.
Not yet. We've got two screens.
It's good. Yeah, better.
Good. So obviously we've tended to use topics for the GI endoscopy session, and we do really are very conscious that we want to try and move it towards the more of an echo orientation and use cases to illustrate learning points, and also cases to help individuals from other areas with the management of their patients. So this is a couple of cases that I've been involved with. I do some colonoscopy teaching at a small district hospital, but I happen to have some good equipment that's been donated. And these are a couple of cases that I've come across in the endoscopy room there. And I'm going to take them through you, and hopefully at various stages ask you to put your hands up or volunteer to unmask yourself and come with some thoughts or some answers, or just post them in the chat and Vikash can deal with that. We'll see how far we get, because one of them's a little bit of a saga and the other one's a very short interaction. So this is entitled To Be or Not to Be, and that's a chronic problem for us in South Africa, as you will see, because we often see individuals who may have tuberculosis because of the high background prevalence of the disease. But the story starts with a 68-year-old male who presented in January of 2022, just over 18 months ago, with loss of weight and abdominal pain. He comes from the Cape Flats, so he's a polysubstance abuser. He takes TIC and a few other things that you may not be familiar with. He smokes cigarettes as well as anything else, and he's got chronic obstructive pulmonary disease. He had a gastroscopy and a colonoscopy and was found to be anemic with a iron deficiency profile. Otherwise, his renal function was normal and his other labs were completely normal. And so this were the findings at his colonoscopy. This was in the transverse colon, and I'll show you another couple of representative pictures. But let me tell you about the colonoscopy. The prep was pretty reasonable, and we got right to the cecum. Cecum itself was normal, and what you're seeing now is in the mid-transverse colon. So there's these sort of polyp, sort of grape-like clusters, and if you have a look at them here, you can see them a bit more in the distance. That's just approaching the hepatic flexure over that corner that you can see there. So you can see these sort of grape-like clusters. They definitely look inflammatory. And there was also this lesion as well, which Again, we weren't sure about, but we snared it, and it turned out to be a metaplastic polyp. Again, interestingly enough, it was in the transverse colon. But this was, apart from that lesion, the lesion of these grapes, this was the actual report. We had multiple specimens ranging from 1 to 3 millimeters. And we also, just because he's from the Cape Flats, we sent some of these tissue fragments for TB culture. But that obviously takes a time, and that's the way that we try and diagnose TB here. We don't use any other confirmatory tests. And on microscopy, lo and behold, we got fairly non-specific findings. And again, with a sort of heavy chronic and acute infiltrate. And there were also crypt abscesses, but there was no evidence of granuloma formation, viral inclusions, parasites, and there was no evidence of dysplasia in the sections examined. And so that was the diagnosis that these were inflammatory polyps. And as I say, the rest of the colon was entirely normal, apart from this sort of transverse colon section of about 15 centimeters or so. So I'd like to pose to you about what we should do now with this gentleman. So I'm quite happy to take anything on the chat through Vikesh, or what people think we should do now. So please just, how should we manage this individual?
There aren't any questions on the chat, Prof. But if I may ask, do you know what the terminal ileum and ileocecal valve look like?
Yeah, they look completely normal. The TI intubation was normal. So there is no classical sighting for TB, that's for sure. But so again, like all things there, patients presenting with weight loss, he did have a chest x-ray. And in fact, the chest radiographs shows that he has pulmonary tuberculosis, and his sputum was positive for a rivampicin sensitive bug. So he was started on a TB treatment in February of 2022 for a 6-month course. And then, like many of these patients, he got lost in the system. So he was then not really being seen about his symptoms, his abdominal symptoms, and the focus had moved to the management of his tuberculosis, and his inflammatory polyps were left to their own devices. So a year later, he presents to the physicians with chronic diarrhea and abdominal pain, and he's chronically unwell at this stage. So again, we would pose the problem, or any questions that you'd have at this stage, as to what we should do now. May seem pretty obvious to some of you, but what should we do now? He's got diarrhea, and the question is, how should we investigate him? Any thoughts from the fellows floating around the place?
No responses in the chat, Prof.
Hey, they're all on top of their game by the look of it. Anyway, let me continue with the story, and we might get to some interaction in a little while. So he, as I said, we decided, or the physicians who were looking after him decided to do a CT scan, and they did a C. diff test, and they also cultured C. diff and confirmed that he had C. diff. And they also checked for TB reactivation in his chest with a chest CT. And there was no evidence that he had reactivated TB. So that's where we got to. And I'd just like to take you through the CT scan. So you can see pretty obviously that he's got quite a lot of free fluid. And you may see here, hopefully it will show, you can see, can you see that arrow? And this is in fact his transverse colon on the section. This again is colon above it, but it is actually going this way, and then it's going that way. And you can see his kidney here. Again, you can see this segment here with no real apparent lumen. And again, this was thought to be ascending colon, but it is in fact the transverse colon. And this is probably the best picture. Here you can see the transverse colon. And if you go along here and mosey along here, you can see how the lumen is. And again, you can see some of the vascular markings here. But if you look carefully, you might see a few other things, but I won't dwell on those just now, and we may go back to this slide in a little minute. So he remained generally unwell, and they repeated the colonoscopy, which obviously was how we got involved, or how I got involved again. Again, I'm not managing these patients. I'm seeing them at the receiving end of their investigations. And you, by looking at the CT, which we had the privilege of seeing before the colonoscopy, we were anticipating some mischief in the transverse colon. So this is what it looked like. And you could get as far as the distal transverse when you reached this sort of stricture. And you could not get the colonoscope past this despite seeing the lumen. And it was really quite narrowed. And that was for about 10 or 15 centimeters. You could see down the sort of hose pipe, very edematous, no real ulceration. But then there was about 10 centimeters of normal transverse colon. And then you came to this. And if you look in the difference in the distance there, you can perhaps persuade yourself that that might be pseudomembranous plaques in the transverse colon. And remember, there is a history that he has C. diff here, confirmed C. diff. But here, at least 15 centimeters proximal to the strictured area, you can see again edematous mucosa, and here is an ulcer. It's a longitudinal ulcer. And it's, again, we biopsied this. And again, we essentially got the same result as the last time, with no evidence of granulomas or any other evidence to suggest malignancy, or any evidence to suggest that he had tuberculosis or anything other than non-specific inflammatory changes. And this again was the area of the stricture, and you can see lots of pseudopolyps, little bits of ulceration and exudate. And again, we took biopsies from this segment. And of course, the story continues, because he remained unwell after the colonoscopy. I'm pretty sure he didn't get unwell because of the colonoscopy, but you never know. And even experienced people can make mistakes with biopsies. But and we took lots of biopsies. Again, we sent them for TB culture. But it was decided, because of increasing abdominal pain and persistent diarrhea, that he should be transferred to Groote Hospital to see the gastroenterology team there and to be assessed by the colorectal surgery team. And he was adjudged there to be clinically obstructed, and they decided to operate. When they operated, they found thin pus, mainly in the lesser sac of around the transverse colon, and surrounded by omentum, which had wrapped itself around the colon. And they decided to chop out the bit of obviously diseased colon in the transverse colon and took out two stomas, because they felt he was hypoalbunemic at this stage, and they were concerned about doing any hookup. So this was actually the pathology specimen. Surprisingly, it surprised us, it surprised me when I heard about it. and there was a complex mass in the transverse colon with attached omentum. Again, there was the story of that he was treated for pulmonary TB. And again, you can see here that there was a small perforation around 40 millimeters from the nearest margin, but there again were no obvious tumors to look at. And when they looked at it under the microscope, you could see that this, in fact, was diverticulitis. Right. Now, diverticulitis is not really something you entertain for a diagnosis in the transverse colon, and I'd be very interested to hear what others have experienced in this regard, especially in the context that we practice in the state sector and other sectors for that matter. And again, you can see there's no granuloma, no parasitic infection, and no evidence of dysplasia or malignancy. So the diagnosis was diverticulitis with perforation and peritonitis. So I just really want to say a few things, and then I'd like to take some discussion on exactly what went on with this patient and whether we could have managed him any better or any differently, because I think there were some thoughts about that. But if this is the best study I know on the distribution, the colonoscopic distribution that's been looked at, this was in about 270 patients. And you can see that in their, these would be African Americans, that the distribution of the diverticula is different. This gentleman that we were operating on is a colored person or mixed race, whatever that means in our context, but essentially they're born, bred and raised and interbred in the Cape, most of them. And so that's designated as a racial group within the context of the state sector, not the state sector, within the governmental differentiation. Again, you can see that transverse colon diverticular, not disease, but diverticular, are least common in the transverse colon of all the sections in the colon. And I certainly, until I heard of this patient, had never seen it. So obviously, when you go back to the literature, you can find lots of them from 1944, 79, 61, in the days when case reports were in the mainstream journals. And again, obviously, these were rare events and only single events when they were written up. So that's where I'd like just to sort of say why we go down this sort of algorithm. And this is sort of old data from 2015, but it hasn't changed much. In fact, in the Western Cape, it's increased even more. But we are one of the highest incidences of tuberculosis in the world. And so we think about it all the time and we're managing it. Of course, 95% of it is pulmonary TB, and we are very cognizant of multi-drug resistant TB and cognizant of it in the differential diagnosis with inflammatory bowel disease in the Cape region. But obviously, tuberculosis and HIV infection go hand in hand. And again, the epicenters of HIV infection, which are not in Cape Town, but in KwaZulu-Natal and other areas, also have a high incidence of tuberculosis. But you can see the purple areas are 750 per 100,000 of the population. So against that background, I'd just like to sort of conclude this case, but I would definitely like to see, I think TB is common, and the environment in which you practice will lead you to sort of think of it and try and diagnose it more frequently than if it's not a frequent occurrence. I think this patient led clinicians down the garden path, and so did his pulmonary TB. And obviously we think if you've got inflammatory disease in the colon, and you're treating him for pulmonary disease, then you're probably treating the inflammatory disease in the colon, despite the fact that he didn't have ileocecal involvement, and despite the fact that we didn't have histological evidence of granulomas in any shape or form in the biopsies that were taken, and in the, obviously, the final pathological specimen. And again, he got lost in the system with his TB to some extent, and due to socioeconomic things, and also his lifestyle choices regarding his substance usage. So he's currently still has his stomas. He's doing well. He's put on weight. He's much improved, and he's awaiting restoration of his continuity when they would hopefully join up his colon again, and he should have no more trouble. And very interestingly, it's very unusual to see diverticula in the transverse colon in the absence of diverticula elsewhere. So he had no sigmoid diverticulae, and he had no diverticulae in the right side of the colon. So on that, I'd like to sort of see what discussion that has thrown up, and we'd be very interested to hear what the wise and sage people also think about it. And then I can perhaps stop the share now, and if there's time, we can look at the second case, which is on a completely different theme.
There aren't any comments in the chat box, Prof. But if I may ask, did he have any diverticular disease anywhere else in the colon? Ascending,
No.
descending, where else?
No.
Yeah.
If you actually go back to the scans, you can actually convince yourself that there are diverticula in the transverse colon on the scans. But we were it's really not like any segment of diverticular disease I've ever seen before. Sometimes you can get some pseudopolyps, but I've never really seen frank ulceration like that sort of ulcer that we saw proximal to the strictured area. And it was really a turn up for the books.
Yeah, I must say I have seen that you very nicely described it as a grape-like mass, and I think those pictures quite well show that overlying mucosa was actually quite normal. They just had those big or larger pits, and that's typical of inflammatory polyps. And I've seen that grape-like mass twice. And the once was bilharzia, and the second time it was sitting right in the cecum at the ileocecal valve, and we biopsied it. And actually, it was in Belgium. It was a foreign national patient, though. And it just came back as inflammatory polyps, and we never quite got down to the diagnosis. But in terms of diverticular disease and that ulcer that you showed, that longitudinal ulcer, so, I mean, the thing that came to mind for me was CMV, but the chronicity of the history. But then segmental colitis associated with diverticulitis. But it seems as if your biopsies didn't show adjacent features of IBD. So there are different types of SCAD or segmental colitis associated with diverticulitis, and the one can look like Crohn's type C with that deep ulcer. But your biopsies also didn't show any features of IBD or any granulomas to even suggest Crohn's in the background. So I wouldn't have guessed diverticulitis for that case, certainly.
Yes. Yeah, no, it sort of put that up. So does anybody else actually see complications of diverticular disease? Or, I mean, you must commonly see it in your endoscopy practice. And again, we're usually, it's a normal finding in patients as they get older. James, have you had any experience with colonoscopy and complications from diverticular disease?
Thanks, Sandy. I was a bit puzzled by the segmental nature of it, and as you indicated in the literature, it has been described. But I just wondered, which is the cart and which is the horse? Did the perforation of another etiology come first, and then that mesocolon and colon became entangled and partially obstructed, and then the diverticular disease followed as a natural history of that segment of narrowing there, or was it just de novo diverticular disease? I find it quite a puzzle.
When you look at the specimen, they were very convinced that there are diverticular there. Again, they're usually ones that get inflammation are narrow-necked. The ones that bleed tend to be wide-necked. At least that's the sort of teaching about it. So I think they were there all along. It is possible that we perforated them, but the CT was done before. So I'm sure that free fluid was there. But he's also hypoalbuminemic. So he had an inflammatory reactionary thing, and he probably had a microperforation. He didn't have feculent peritonitis. Otherwise, that would have been easy to diagnose. So he would have popped a small diverticulitis. The omentum, even more so than in the sigmoid colon, would wrap around it because it's just right there, so-called guardian of the abdomen. So it wraps around it to sort of try and prevent it. The other thing that nobody's mentioned is amoebiasis. So we do see that in the Cape now. It's very unusual. And when I was in Durban, we wrote up 4 cases of Caucasians who got it. Incidentally, one was an old lady who was in an old age home, diagnosed as appendicitis, but she had an amoeboma. So you also have to pay attention to the fact that with the Eastern Cape migration and that sort of thing, that you may turn up diseases that you don't normally see in your region, and you must bear them in mind. But again, amoebiasis looks much more florid and much more ulcerative with the typical flask ulcers. It didn't look like amoebiasis to me. And he never really had an acute dysenteric illness. He had a sort of chronic diarrhea.
Thanks very much. That's comprehensive. I'm just wondering, as you were talking there, the chronicity aspect. Does one find chronic diverticular disease with hyperalbuminemia and all sorts of wasting disease and being so unwell for such a long time? Is that the feature of diverticular disease?
So the whole thing, the whole clinical picture doesn't fit, but I think he obviously had tuberculosis, and it's difficult to know exactly what was going on with that. I mean, it is possible that they got rid of all the granulomas with his TB treatment, but obviously we didn't find them the first time round either. So, but again, many of them might not be in the mucosa. And obviously, traditionally, it's posobacillary. So even when you take it out, they also have to look hard for it. So I'm not quite sure how hard the pathologists look for it, but it is, unfortunately, the pathology is sort of, it's quite black and white, unfortunately, the report. Yeah. There's no sort of hint that this is TB, no caseation, nothing of that sort whatsoever that you'd expect from such a long-standing history. But I'm sure he was smoking a bit of this and that in between times, which doesn't do your nutrition any good.
Okay, thank you.
Yes. I'd be interested to hear from anybody else. Christian in the Cameroon, do you see diverticular disease there? Are you there, Christian?
Yes. We used to see that because very often, and we do, as you said, no special condition in that, and we do quite the same treatment you have suggested.
Okay, thank you. I think we're.
Vikash? Hi.
Yes. Hi.
Yes, so I just wanted to mention that case that we had, that lady who had complicated diverticulitis with abscess formation, who wasn't responding to antibiotics, that we eventually had to do a lumen-opposing metal stent for, I think it was for diverticulitis, if I remember well, with abscess formation.
Yeah, that was quite an interesting case as well. It was a lady with Cushing's disease, actually, who had a lesion in the adrenal, and she had a adrenalectomy done, and there was a rectal abscess, which was not addressed or looked at the time of the adrenalectomy. And she did have diverticular disease, and she had this rectal abscess, which was most likely a complication of the diverticular disease. But there was one thing missed on the history. She did give a history of feculent or pussy material being past PV as well. And we didn't have that history. We actually proceeded to drain her via EUS with the rectal abscess. So we placed a lumen opposing metal stent from the rectum into the abscess. And it drained quite well, and a repeat CT scan, that collection reduced beautifully in size. We were then concerned afterwards, because we actually got the history of the PV discharge afterwards. We were then concerned that we might have now created a rectovaginal fistula. But after removing that lumen opposing metal stent, I think with the decrease in that abscess and the decrease in the pressure, rectal discharge also completely resolved, and she did quite well. With the underlying Cushing's, she was probably, in an immune suppressed state, which also didn't help. But that was addressed with the hysterectomy, and she did quite well.
Traditionally, the inflammatory complications that you would get are to do with the bladder and with sigmoid, and obviously they can be associated with an abscess. And again, in females, that abscess can sit deeply in the pelvis, because the rectum doesn't have any diverticula in it at all. So the abscess then if you get a colorectal fistula, it's coming from the disease penetrating into the upper third of the rectum. Again, sort of drainage of abscesses, I think that's a novel way to do it. And obviously in someone who's immune suppressed and steroid dependent, it may be a reasonable solution. And they also get vesico, they get vaginal fistulas as well. So the sigmoid sits down in the pouch of Douglas. So again, it can perforate there in a complex mass. But those are the traditional complications of diverticulitis that almost exclusively in the West reside in the sigmoid colon. They really don't manifest elsewhere. And the only other odd place that you get diverticula is in the cecum, usually, that complicate with appendicitis-like symptoms. So the transverse colon is really just, it's a bit of a hen's teeth sort of affair. And again, I think we did the right things with this patient, looking for TB, managing the TB. But, and again, we probably wouldn't have managed him any differently in terms of if we even known it was diverticular disease. He would have had to earn his operation, so to speak.
Thanks.
Yeah.
Dr. Sandie, have you ever seen many segmental colitis and associated with diverticulitis, number one? And have you ever seen that inflammatory sort of mass associated with diverticular?
Who's that addressed to?
Dr. Siabi, sorry.
Yeah.
No, I was just saying that, no, I haven't. I've never seen such type of...
We had a lady who, again, sort of inflammatory bowel disease and diverticulitis of the sigmoid colon. We had a lady, she's still in the clinic, and she presented with pneumaturia, with a proven diagnosis of Crohn's disease. Anyway, it turned out she had both diseases in the colon. We actually wrote her up in the Gastro Review about 8-10 years ago. But that's the only case but it's well documented that you can get inflammatory disease within sigmoid diverticular disease. And the two can coexist. This lady was actually on anti-TNF when she perforated. And the only way we knew that she perforated, we got her to pee in the bath. So that's the only way you know if a lady has air in her urine. Whereas males will tell you that they're passing air in their urine if they have a diverticular fistula. But the ladies, you have to ask them to pee in the bath, and then the air percolates through the bath. So that's a very good clinical tip if you want to diagnose diverticular disease with a vesico sigmoid fistula. That's one's for the old guys amongst us. Yeah. Anyway, there is another case which is quite interesting and a little bit shorter, but I think poses some diagnostic quandaries, and also is the sort of case that we would like to see from those of you who are participating in the webinar from other countries in Africa. So I'm going to share my screen again, and this will be much shorter. So this is a surgical case report, or a surgical patient. Yeah, hopefully.
You want to present?
So this is a 34-year-old male. He presented with
Sandie, just
Yeah.
put it in presentation mode, please.
Well, you can't see it. Okay.
No.
It's not in presentation mode at all, or it's the wrong way around?
It's the wrong way around.
Okay.
Want to swap display?
Yeah. Let me just try and move this thing. Yeah, we're good. Are you good?
Not yet, no.
Okay.
Not on my side, no.
Okay, let me just stop the share and start it again.
Okay.
Which way around is it now?
Not yet. Probably have to swap displays again. It's not in presentation mode yet.
Well, according to this, it is.
Now it is. All
Now
good?
you've got it. Okay. So, so this is a 34-year-old male who presented with progressive poor effort tolerance over 2 months. He lost weight of 8 kilos. He is now 52 kilos. He had no gastrointestinal symptoms, and he had a profound iron deficiency anemia. And these were his parameters. His hemoglobin was 2 when he presented to the physicians, which is pretty low for people to function at all. But he was functioning with it. And obviously, this was a chronic anemia. And you can see his iron parameters below. So he was pretty profoundly messed up. And obviously, not to spin it out, what should we do now? Well, he needs transfused, certainly to improve his effort tolerance and to make him functional. How much you should transfuse him and whether you should give him an iron infusion, that's probably open to debate. But the tendency now is to use iron much more liberally. You obviously want to take a proper family history, and there's absolutely no family history that was relevant at all. Nobody in his family have any cancers of the stomach or the gastrointestinal tract. He had an upper GI endoscopy, and he was scheduled for a lower endoscopy. And in the meantime, he had this CT scan. And he didn't have a palpable mass, but on CT scan, you could see this mass lesion that's indicated there on the venous phase. And it looks like he has a single metastatic lesion, which also shows up on the arterial phase. It enhances slightly in the arterial phase. And it's somewhat unclear. Again, here's another picture of it. And you can see just the tip of the liver just at the bottom here, and the mass occupying the lumen here. So we obviously went ahead to do a endoscopy on the patient. And this is just round the corner at the hepatic flexure. And you come across this narrow stricturing tumor. And again, that's the best picture. That's during the biopsy. You can't get past it. And interestingly enough, just about 4 centimeters proximal to it, there is this adenomatous polyp up at the top. And we biopsied this lesion. We didn't take the polyp off because we thought that was completely unnecessary given its proximity to the cancer. We saw no other polyps, but unfortunately his prep was pretty poor, and we actually used a mixture of irrigation and a variety of things because we knew we had to get to where we were getting despite the poor prep. So we can't really say that he doesn't have polyps in the rest of the colon, but he had nothing obvious that we could see. But he definitely had a polyp proximal to this, what looked like a cancer. And this is the configuration of the scope. Very unelegant, unfortunately, but we really had a great deal of difficulty getting around that last corner, and that's how it ended up. And we stated it there. So the biopsy confirmed an adenocarcinoma, and perhaps, I don't know if there's a fellow you could put your finger on. We could ask him what he should do. What should we do now? So we've got a CT that shows there's maybe a metastatic lesion in the liver. We've got a tumor that looks as though it abuts the liver if it doesn't involve the liver directly. And the tumor is located in the ascending colon, just round, as far as we're aware, the hepatic flexure from clinically, both from the CT and from the image on the scope guide. So we are sitting at a small district hospital, which runs, has a surgical service run by consultant general surgeons. But we felt, given his age and given the metastatic disease, that he really needed to go to an MDT. And these are the things that we think will be relevant to his management going forward and why we sent him there. We're unsure what his optimal management would be, and we do believe that there are a few options as to whether he should have chemotherapy before and have supportive treatment, obviously, to sort his anemia out while that takes effect, or whether to alleviate his ongoing anemia, because we're not really going to be able to address that in the long term by doing that. What kind of surgery can he have? And indeed, is this mass actually resectable? So again, this is a 34-year-old gentleman. He's a colored gentleman. And so that raises also some other questions that maybe we can comment on. So that's a brief little case of a terrible situation for this gentleman who's obviously been becoming anemic over a long period of time, probably many years, to be honest. And obviously, it's simply just caught up with him in the last 2 months. I'm not sure what his overall prognosis is, but I think it must be guarded, to say the least. So I'll stop the share there and happy to take some discussion on the case.
There aren't any comments in the chat. Would anyone like to unmute and comment? No.
So I know I'd be interested to hear from some of our other African countries as to how often they see their cancers in patients of this age, because it's notoriously a cancer of younger Africans in most countries in Africa, as far as the information has enabled things. So please, the whole object of the exercise is to hopefully have some interaction from you. So do you see young patients with colon cancer in their 30s?
Yes, Sandy. We have a lot of such cases. We had to publish many years ago that we was surprised to see such young patients in Africa, in Black Africa, with colon cancer. And now it's well known in Africa that it is quite usual to see patients under 40 years with a cancer. And to take care of that is very difficult because they used to come to us very late, very, very, very late. So we have only palliative solutions for them. And from time to time, we have some success, but usually it is not good. Very prognostic is very bad. So we have a lot of this sort of cases.
The best comparison that I know of, or the only comparison, is with Nigeria and the Memorial Sloan Kettering. But it's interesting that African patients generally are meant to present more with peritoneal metastases rather than liver metastases. And obviously that's even more of a game changer in terms of prognosis. It's a problematic. And this gentleman is not, he's a colored gentleman. He's not a African gentleman. But I think internationally, certainly many of the people are now starting to screen for colon cancer in their 40s for sporadic cancer. So the age range is reducing. I don't know if there's anybody who would like to make comments about sort of that aspect of it. And I think obviously people are exploring different pathways from the Vogelstein pathway for cancers to occur at younger ages. And I think there are a lot of other mechanisms that these cancers can arise in. That would also bring you to sort of try and test these patients for cancers that are occurring at a young age by doing microsatellite instability on the specimen and looking at immunohistochemistry. So I think those are avenues that are being explored. Vikesh, you must see a fair number, because you've got an urban practice with a reasonable proportion of African patients of African descent, for want of a better description.
Yeah, we're certainly seeing the same pattern. A lot of younger, aggressive, late cancers in their 40s, young patients. I seen just sort of interest, Prof, that polyp, did it come back as an adenoma?
We didn't take it out.
The biopsy? Did you biopsy?
We didn't biopsy it, but we biopsied the lesion. The lesion is an adenocarcinoma. Okay,
just out of interest. I've also, in fact, just about 3 or 4 weeks ago, scoped a young 24-year-old gentleman, a colored gentleman as well, who had he presented similarly, with an iron deficiency, anemia, and PR bleeding, essentially. And he also had a large sigmoid adenocarcinoma. But it looked like it was on the background of a cess-ulcerated lesion. So there was area with more structure, which looked very cess-ulcerated to me. Yes. It didn't quite meet criteria for SPS. I didn't find any other cess-ulcerated lesions in the rest of his colon. So it was just that one large one in the sigmoid that had progressed to cancer. He's done quite well. He's had his resection, and I think he's doing quite well. He had one node positive. Again, young, healthy, otherwise well male patient. But we're certainly seeing the same trend in Joburg with younger patients being diagnosed with these aggressive cancers. Yeah. Did you have any genetic studies or any MSA?
No, so I think that the big thing here, I think there's two approaches to him. He doesn't have a family history as far as we could ascertain. But if you have people who are looking at it, who have counselors, then they can take a better family history than clinicians and look into it. And obviously, when you've got these Lynch syndromes, there are other cancers that you're looking for as well in the family history. So that's important. And again, I think that the whole business is, what would you do if he survives and he has children? What are you going to do about them? Because even now, certainly in the Zimbabwean series, only about 4 out of 100 had a Lynch syndrome. So it's still not phenomenally phenomenally common. And I'm still not sure what the mechanism is of, why they have an accelerated growth. Because obviously these serrated stories are related to methylation, and they occur, the transition to cancer is much quicker. So in the Lynch syndromes, obviously you're going to scope them every 2 years. So again, we're not really sure what the interval should be for some of these cancers on the right side. But again, it could be a serrated pathway in him, because obviously it's a right-sided lesion, and maybe, biopsying the polyp would give you some information there, but I don't think it helps you manage him very much. It just would be interesting to know if that associated polyp was, you could maybe then hypothesize that it might have been the original polyp.
There's no other questions in the chat box. Any other comments?
Sandie, is there any doubt about the liver? That is a convincing metastatic lesion in the liver? It's not
So again, I sort of, if we were to go into it in detail, but I think the question is whether, I haven't really looked at the CT scans, and some of the scans that are done are not really done with a proper protocol. So it's very much worthwhile looking at another modality. And I think MRI now is taken over as the preferred choice for looking for these lesions, even for metastatic disease. But I think a high quality CT scan is very good. So they need to be reviewed in the MDT and the characteristics of that. The thing with this gentleman is that the mass does abut the liver. It almost looks as though it invades it on some of the scans. So if you're to take it out, you might be able to, if that's the only lesion in the liver, it might come out with the specimen if that's the desired goal. But it would be nice to, I think, to try and give this chap, once you've staged him properly again, to give him chemo and to see what happens to the size of this thing. It may make life an awful lot easier to take it out. Because obviously you want to take it out. You don't have a solution for his anemia without taking it out. So it would be nice to know if this thing is chemosensitive. And I think if you transfuse him, he's not obstructed. Traditionally, these right-sided lesions don't obstruct. And so if you give him chemo, he may well shrink it. And then you're in a better position, I think, with maybe simpler surgery and deciding on whether you're going to tackle the liver at the same time or at a different time. But that's why he really needs to go to an MDT where all these aspects can be discussed and the optimal management made out for him. He doesn't seem to have any other comorbid problems. So I think if you get his hemoglobin up at 10, he'll be functionally a new man. Because how he's been soldiering on with a hemoglobin of 2 is quite amazing. 2, yes. I also thought that, but it's true. So I think, anyway, I hope these 2 cases sort of illustrate the value of colonoscopy. Obviously, we can debate what else we could do at colonoscopy in certain of these lesions. But I think they were certainly interesting to me and unusual in their presentations, but not the latter, at least not completely unusual. So I hope you found them informative, and I hope they've given you some clues as to how you should go about managing them and where colonoscopy sits in the diagnostic pathway. Okay. Thank you very much. Thanks, Vikesh.
Thanks, Prof. Thanks for sharing those interesting cases with us. Quite thought-provoking, and yeah, I think it forces us to look deeper into colonoscopy and think more broadly. So thanks for sharing those cases with us. I think just in closing then, just to thank iEcho from the University of New Mexico, as well as iEcho India team. And just a reminder that the recordings for all of these meetings are available on the Gastro Foundation website. Thanks to the Gastro Foundation as well as the sponsors. And then just 2 reminders. Next week would be the PEDS presentation. And to anyone who's not aware, there is a endoscopy interest meeting group being held this Saturday. It's a revival of the endoscopy interest group via the Gastro Foundation of Sub-Saharan Africa. So it's the first meeting being held, and there are some prominent international speakers joining as well. It will be hosted live in Joburg, but there is the capability of attending virtually as well. So if you're interested and if you haven't registered, please do so. It should be an exciting program. Thanks all. Any last comments before we close?
Good.
Cheers. Thanks.
Thanks very much, everyone. Bye-bye.